course. And you know, before we're done, I certainly want to talk about this concept of opioid rotation, which we've heard about for years now. Chris, what are your thoughts on changing opioids? Why would you do it? How would you do it? Is there any rationale to doing it?
I think there's tremendous rationale behind it. We're sort of in a different era than, let's say, 10, 15 years ago. I think Joe and Vitaly and yourself brought up some great endpoints that we're trying to achieve. Now, there will be gradual lack of response over time. It sort of develops insidiously due to development of tolerance. Other side effects may surface at some point due to a variety of reasons, but the most common encounter as the treatment continues is lack of efficacy. So as we lose that efficacy, it used to be that we used to go up on the dose. But I think we're entering a new era where opioid rotation is going to be more and more important. So instead of continuing to go up on the same compound that the patient responded to, our new strategy should be opioid rotation to something else, to another molecule, to another opioid molecule, and then bringing that to effect. Now that comes with certain education to the patient. And to other referring physicians, that this rotation is quite imperfect. It's really a rough guideline on how we're going to switch the patient over. There's going to be physiological accommodation to the side effects. The side effects will dissipate over time, and the pharmacodynamics and the efficacy will improve over time. And that conversion may take anywhere from a couple of weeks to a month or so, but the effect will ultimately be comparable.
You know, tachyphylaxis happens with these drugs. I mean, that's just a natural response at the receptors. And then, you know, we have to be able to educate our colleagues the difference between tolerance and other things like opioid-induced hyperalgesia as well. So it's critically important to do that, I think.
Yeah, and you know, I think one thing clinicians miss over time is whether or not the reason for dose escalation is tolerance or disease progression or aberrant behaviors.
Or non-compliance.
Or non-compliance, absolutely.
You know, they're just not taking when they should.
Sure. Any comments about opioid rotation?
Well, I agree that there is not, should not be a cookbook approach to this. You really should exercise caution because there are multiple subsets already discovered by basic scientists of opioid receptors. There are multiple subsets of mu receptor. And the tide has changed. We used to be 1 or 2 opioids that we were prescribing, as Chris mentioned, 10 years ago. Now we know that each opioid has its unique properties and binding to a unique subset of mu receptors and other receptors, opioid receptors. So, you know, I really would like to use the conversion tables. We all know that they're imperfect. We all know that you need to exercise caution when you convert, really err on the cautious side. I'm not going to necessarily say whether this is a 20 or 30% decrease. I just said that. But at the same time, I really don't want to use just a cookbook approach and say, this equals to this.
Of course, and just so our viewers recognize that the package inserts for some of the drugs actually make those suggestions. Hey, do the equianalgesic potency calculation and cut your dose by 50% or 25%, all in the name of safety. Well, clearly when we